Uh, we can start, Dr. Asif. Hello. Dr. Asif,
Yes,
we can start.
sure. So I go ahead with the topic.
Please.
Thank you. So good morning, ladies and gentlemen, and thank you so much to Dr. Srinivas and Dr. Gansham for giving me this opportunity to speak on this forum. And the topic for today's discussion would be acute brain injury and what are the hemodynamic targets. So as we all know, in our day-to-day practice, when we talk about brain injury, the first focus that comes in the mind is basically a traumatic brain injury. But it's just one component of the acute brain injury that's happening. There are other features like stroke, any other acute emergency happening as a result of any pathological state going in the brain. All these can result in a primary brain damage, and that is the acute brain injury that we talk about. And what is important is we always focus upon the secondary brain injury subsequently. But it's very imperative and important that we also try to maintain the targets, the different parameters, basically to prevent the secondary brain injury. And that is done immediately. And that is done at the time when these patients come to us in a day-to-day practice. So what we are going to talk about, basically the focus on, there are multiple factors, in fact, which are responsible for management of brain injury. But one such parameter comes out of it is the hemodynamic targets, where there is a lot of ambiguity. Not so because it's not something known, but people have been given different targets. People have been given different references. There are a lot of literature, but they do not have much of evidence, much of strong recommendations. So what we're going to do today is understand as to what are the hemodynamics which are involved and what are the targets that we need to maintain, simplified basically based on the guidelines and the recent references as to what we should be doing when we deal with such patients. So if we have a look in a clinical scenario, like you have a patient with acute ischemic stroke. He has a GCS of 12/15, his heart rate is 90 per minute, and he has a blood pressure of 150 by 90 millimeter of mercury. Now, in the similar instance, you have a patient of acute hemorrhagic stroke who is having the same parameters. Talk about a GCS of 12/15, a heart rate of 90 per minute, and a blood pressure of 150 by 90 millimeter of mercury. So if we have to look at the parameters, he has the same GCS, the hemodynamics are the same. Now the question comes, are these two parameters fulfilling the criteria for management of these two situations? Is it okay if we maintain a blood pressure of 150 by 90 for both the situations? Fairly not very high, and most of the literature talks about maintaining not a very high blood pressure, not a very low blood pressure too. So what do you think if it is okay to have this blood pressure for both these conditions? Well, we'll be looking for some more answers. Now, look about a patient who has come to us with traumatic brain injury. He again has a GCS of 12/15, his heart rate is 90, and his blood pressure is 90/60. Now, is this blood pressure suitable or adequate for a patient of TBI? So, to have a look at these answers, basically what we will do is we will go into the understanding of the hemodynamics and also whether these hemodynamics are acceptable. And what are the hemodynamics that we talk about? The heart rate, the blood pressure, the systolic blood pressure, diastolic blood pressure, or fluid status. Now, in a day-to-day practice, when we are dealing with such patients, which are the parameters that we should be focusing upon? There are so many modalities available to us, the clinical signs, then you have the different basic and the advanced monitoring devices available to us. So is it possible that we apply all these parameters in every single patient who's coming to us with an acute brain injury? Maybe yes, ideally, but if we have to look at the practical aspect, it becomes quite difficult to apply all this in our patients continuously, and a number of patients where they're admitted in your ICU and continuously. So let us go basically to the understanding. As we all know, the high and low blood pressure both can cause organ dysfunction during acute brain injury. The high blood pressure can result in increase of hematoma, it can cause edema, and it can lead to a hemorrhagic transformation of an ischemic stroke. Whereas a rapid and significant reduction of blood pressure, if you think that we're going to do better by bringing down the blood pressure, and that is in rapidly, that can lead to reduced cerebral perfusion pressure, resulting in an increase of the ischemic area. So we're trying to get some parameters right, but what is happening, the outcome of this parameter control or change is actually affecting the patient on the bad side. So looking at the different parameters that we talk about, basically to start with is the cerebral perfusion pressure. That's the driving pressure of the blood in the brains. And this is basically calculated by a difference between the mean arterial pressure and the intracranial pressure, or the CVP, whichever is higher. So normal range for this is 60 to 70 millimeter of mercury. This is just a revision of what are the parameters which are to be acceptable at a particular level. And then we talk a lot about the cerebral blood flow. Basically, this is the flow happening in the arteries, in the vessels, in the brain. And this is calculated simply by the difference between the mean arterial pressure and the intracranial pressure divided by the cerebral vascular resistance. So to make it more simple, the value is around 50 to 60 ml per 100 grams of brain per minute. Now, as we all know, the average weight of the approximate weight of the brain is around 1.3 kgs. And this accounts for only 2% of the total body weight. Whereas if you talk about the blood that is circulated, that's around 750 to 900 ml per minute, and it accounts for almost 15 to 20% of the resting cardiac output. And that's where the metabolism of the brain is very important, because the anaerobic metabolism of the support is minimal, and the brain is completely dependent on the supply of nutrients and oxygen through the continuous blood flow, which is happening at a high volume. Now, to maintain the integrity of the brain and the function, the cerebral blood flow is tightly controlled. Otherwise, there'll be a lot of fluctuations happening, and this will all result in a lot of problems, both on the higher side and the lower side, because if there is a linear proposition or a linear relation with the parameters which are seen. So what is actually seen, a protective basic mechanism of the brain, is that despite having a lot of changes in the blood pressure and the cerebral perfusion pressure, the cerebral blood flow is quite maintained in a particular level, so that it does not have an impact drastically on the brain. And if the cerebral blood flow goes to as low as 20, we know that the neurological impairment and damage will begin to happen. Now, there are a lot of parameters which are dependent on, and it is basically the cardiovascular system, it is the blood pressure and the cardiac output, which also decides the cerebral blood flow. Then you have the intracranial pressure, an important component, the three components of the brain function, and any increase in the ICP can result in a decrease of the cerebral blood pressure, perfusion pressure, as well as the cerebral blood flow. And then what is happening at the level of the arterioles and capillaries, that's also important, whether it's a dilatation or a vasoconstriction, which can affect the flow happening at the level of the brain also. So these are different components which do affect the cerebral blood flow. And to have a larger overview, look at this. How every single parameter is affecting the brain directly or indirectly. You have the cardiac output, you have the cerebral autoregulation working in tandem, in parallel, basically to control it. Then you have the parasympathetic and the sympathetic nervous activity also having impact. And then it is grossly affected by the different derangements which keep happening as a result of acute brain injury. That is what we are concerned about. Now, the basic principle is that the dynamic cerebral autoregulation is a physiological process, in fact, that maintains the cerebral blood flow relatively constant with a change in the blood pressure. So even with a change of the mean arterial pressure going down to as low as 50 or increasing as high as 150, the tendency of the brain is to maintain a constant cerebral blood flow so that the dynamics or the milieu is not affected in the brain. And that is a strong regulatory mechanism working in the brain. So what happens? Suppose the blood pressure becomes very low, then below this 50, then your cerebral blood flow becomes dependent on the cerebral perfusion pressure and the MAP, and subsequently the cerebral blood flow gets compromised. So when we have a MAP of around 50 to 150, this protective mechanism works, but subsequently it does create a problem. And that is what is actually seen when these patients come to us with acute brain injury. Look at this complexity. In fact, it's just the same that the whole process is basically to maintain the cerebral perfusion pressure between the mean arterial pressure between 50 to 150, and you see that the blood flow is relatively constant. And then on the top, you find so many parameters we have just seen. So it talks about the complexity with which the brain works, but only with one purpose, that the cerebral blood flow is maintained and the milieu is not disturbed. There are three mechanisms which talk about the maintenance of this autoregulation. I think this is important for understanding before we go on to understand what are the targets that we should be looking forward to. So one is the myogenic or the pressure autoregulation. The other one is this neurogenic autoregulation, whereas the third one is the metabolic autoregulation. So the neurogenic autoregulation does not contribute much. Mostly it's because of the myogenic as well as the metabolic autoregulation, but all of them become a part of it. So what happens? Basically, the arterioles which are dilating or constricting as the changes are there in the pressure within the brain, these are responsible for the maintenance of the cerebral blood flow. Where it constricts, whether it dilates, the flow increases, if it contracts, the flow decreases. So this is the primary change which controls the autoregulation. Whereas you have a very good sympathetic nervous system, which is supplying the brain, and that is again affected by the change in the pressures from high to low. And what happens is this again bring about indirectly the changes happening in the brain vessels, and they start constricting, and then you are able to control the high pressure which is happening as a result of a high MAP or a high cerebral perfusion pressure. And so a constant blood flow is again maintained. Metabolic autoregulation comes into play because of the different arrangements which happen as a result of the acute brain injury and when the patient is going for a secondary brain injury. And that is the time when you can see the different components which come into play, the severe metabolic as well as the hypercarbia parameters, and then you have hypoxia coming in, all reasons which are resulting in a secondary brain damage. So that's how it gets related. The CO2 concentration, any increase can cause vasodilatation. The H plus ion concentration as a result of acidosis can depress the neurons initially, and subsequently it does increase the cerebral blood flow. That's how the corrective mechanism comes into play, because more of blood flow takes off the increased H plus ions. And then an oxygen concentration, when it comes down as a result of hypoxia, then any decrease in the oxygen concentration again would result in increased cerebral blood flow. So that's how it goes. So this is, again, I just want to stress on the same parameter. You have an autoregulatory range between 50 to 150, you're quite comfortable. Below that, you have cerebral hypoxia. Above that, the patients develop edema or they have a disruption of the blood-brain barrier. And what is actually seen is that you are able to maintain in that center portion, the autoregulation, but above and below that, it becomes quite beyond going off our control, and there is a lot of damage that's happening. So it is quite imperative and important for us as clinicians taking care of these patients that we try to maintain the mean arterial pressure between this range. But that's a very wide range. So the purpose of having hemodynamic targets are you get very clear-cut, not very vague or ambiguous guidelines, and that's what we'll be looking forward to. So there are so many parameters that are working for the maintenance of the cerebral blood flow. Now, is it possible to get a continuous NIRS or a MRI or a spectroscopy, EEG, or PET scans, Doppler flow, blood pressure measurements done constantly in a patient? Yes, for some patients who are having severe derangement, it would be very ideal and it's actually required to. But that's not possible in all the patients who are coming to us. It depends on the center that you're working in, the specialties which are there, the protocols and the guidelines, and the availability of equipment and expertise is also important. So I think these are different parameters which really kind of affect the management of these patients. So we need to have simple parameters, simple targets, which we can apply in our day-to-day practice. So the other concern is basically what affects this autoregulation. So here comes the role of your acute brain injury. And as you can see here, any hypoxia because of any reason, it can be stroke, be it any other reason, or associated complications which happen. Then you have trauma from brain injury, or you have a brain compression from tumors, hematoma, or a cerebral edema. So anything that is affecting the normal milieu or the normal functioning of the brain actually is a stimuli for causing acute brain injury, and it can disrupt the autoregulation, hence the importance of maintaining the parameters. More so if you see in patients with traumatic brain injury, which almost take a good chunk of brain injury patients when we talk about. So see how the phase-wise changes happen in the brain. And that's the complexity. You see initially you have a hypoperfusion phase, which is almost 1 to 3 days from the time that it started. You have cytotoxic edema, the ICP starts increasing, and that's followed by a hyperemic phase, 7 to 10 days. And this is the time when you have vasogenic cerebral edema. And subsequently, you have a vasospastic phase later when you have again impaired regulation, where the arterioles have vasospasm, and all this starts affecting the functioning of the brain. So basically, all that is just to let us or let you all know that this is how the complexities of the brain function works. And that's how whenever we get acute brain injury, what happens subsequently in the brain, and it is so very important for us to maintain the different requirements. Now, next is the cerebral perfusion pressure. As we know, it's dependent on the mean arterial pressure and the intracranial pressure. So ICP, whenever it's increasing as a result of tumor, edema, or bleeding, that will compromise on the cerebral perfusion pressure. And the ICP increase actually collapses the veins, decrease the cerebral perfusion pressure by reducing the blood flow. So we have to also maintain the ICP at a level and also a mean arterial pressure at level so that the cerebral perfusion pressure does not fall down very low, because again, that will be having an effect on the cerebral blood flow and the supply to the brain. Importantly, what has come to understanding now is the brain-heart crosstalk. So what was thought about as an accompaniment, or what was thought about as a coincidence earlier, like patients who were having primarily a brain injury or a brain damage, there we were finding a lot of other cardiovascular happenings coming about, which were thought to be as a coincidence, or it could be because of underlying problem. But now what has come into play and our understanding is that whenever there is a brain dysfunction, the heart equally responds to it in a form of severe dysfunction because of the crosstalk or the interconnections that we have. So if you see that whenever you get a prefrontal cortex involvement, there will be impaired autonomic cardiac control, which will be happening. And that is evident by the different hemodynamic changes, which will be seen on a patient who is having any kind of a stroke in that localized area. Any insular-related problems in the brain, these patients are prone for atrial arrhythmias, they are prone for myocardial injury, and they are prone for Takotsubo syndrome. So we should be correlating whenever that symptoms or such problems happen, then we have to correlate as to if there is an associated problem in the brain, and that is how you can talk about the correlation between the heart and the brain. Patients having a lesion in the hippocampus, they can develop hypertension, they can develop tachyarrhythmias like atrial fibrillation and heart failure. Whereas whenever you have a brainstem injury, we know that there are ventricular arrhythmias and bradyarrhythmias happening in all these patients. And all these arrhythmias are affected through the hypothalamic pituitary adrenal axis, and that's how it works. And you'll be seeing patients developing arrhythmias without much of underlying cardiac problem whenever they develop an acute brain injury. So the importance of all that we have heard and seen till now is that the maintenance of the cerebral blood flow, the cerebral perfusion pressure, and that can be done mostly by maintenance of the mean arterial pressure, is important for preventing secondary brain injury. Now, having optimal hemodynamic management, easy to say, but this is the keystone for preventing secondary brain injury. That is how we will be able to reduce mortality and morbidity. But no doubt, it's a challenge because of its understanding and also because of its application. But let us make it simple and let us make it evidence-based so that we are quite confident with whatever approach that we apply. So guidelines, as we know, develop over a lot of collection of evidences and lot of the rationale that is put into its place, then only it will be put up so that we are able to follow those guidelines. So based on the evaluation that was done through the physiological studies of the different effect of hemodynamic management on cerebral physiology, that was the brain crosstalk that we talked about. And then you had clinical evidences from the large observation studies, basically to find out the current clinical practice. And then you had the large RCTs done to define what are the future clinical pathways, what impressions do we take, and what should be done in the future to make it easier for our understanding. Comes the different guidelines, and this is a consensus statement or recommendations basically on what to be monitoring and how to be monitoring in a patient with acute brain injury. So that's the basis of the guideline. So let us now go through and understand what the guidelines say and also what we should be doing in terms of management of the hemodynamic targets. So quickly, let us pick up one by one because the parameters will be different for each of these different components of the acute brain injury causes. Like the first would be the acute ischemic stroke. So this trial called the INVEST trial, the intravenous pneumo-dependent West European stroke trial, was done way back in 2000. And what they found was there was a statistical significant death rates with decrease in diastolic blood pressure, decreased by more than 20% from baseline, or with a diastolic pressure of less than 60 millimeter of mercury. So I think that was important, which talked about the decrease in the diastolic pressure by 20%, and there was a difference in the death rate. So based on whatever guidelines that we have had, what is normally practiced or told is that the blood pressure should be maintained at less than 220 by 120 millimeter of mercury if reperfusion therapy is not planned. If you plan a thrombolysis or endovascular intervention, then the blood pressure should be less than 185 by 110. And once you have done this thrombolysis or endovascular intervention, then it should be brought down to less than 180 by 105 for 24 hours. Even though you find that the diastolic comes down from 110 to 105, it's not just assumption or it's just not an arbitrary figure. So these are basically what have been taken from the studies which have shown that it does have an impact. Whereas in situations where the blood pressure is more than 220 by 120, then we should be, or in patients who are having cardiac failure, aortic dissection, and a hypertensive emergency, and any abrupt lowering of the blood pressure, like I want to bring it down to 140, 130, should be avoided. The initial lowering should be done by around 15 to 20% in the first 24 hours, and we should be very gradual. Otherwise, instead of doing benefit, we'll be doing harm. Now look at the different guidelines. You have the AHA, American Heart Association, you have the European guidelines, you have the Society of Neuro Association, then you have the different guidelines coming at different levels. Maybe 2014 you had one, you had 2018, 2019. So look at it. They talk mostly about what are the status, basically whether any reperfusion strategy is planned before giving a thrombolysis, before doing any endovascular treatment, what after an endovascular treatment. So you'll find a lot of difference in whatever parameters that are shown, the recommendations. Like one talks about less than 220 by 120, others talk about 185 by 110 after therapy, 180 by 105, whereas during endovascular treatment, the diastolic is told to be maintained between 140 also, much less than 180 that we saw above, and the diastolic less than 105. And then the European also talks very similar. They talk about having 105 is the diastolic in the initial part also, and post the endovascular treatment also. So basically, if you see, you can pick up any of the guidelines, but there'll be some variation, no doubt in that. But to make it simple, a consensus comes from the different guidelines. So what we should aim and what we should practice for any patient who's coming to us with acute ischemic stroke is that you should focus on the target systolic pressure based on whatever we have seen in the different guidelines. Try to maintain this target systolic pressure to less than 180 at the earliest. Obviously, when you have to see to the point that it's not a drastic fall and it's less than 15 to 20%, and then you maintain this systolic blood pressure for at least 24 hours. I think that's a simple message and a simple protocol that can be applied for our patients in our unit, and that will also do good to the patients. Now, talking about acute hemorrhagic stroke, again, a good number of patients keep coming to us. So we all know that any high blood pressure can lead on to increase in the hematoma size, and that will result in a poor prognosis. So the importance of blood pressure control is enormous. And what has been recommended is that in patients who are having an acute hemorrhagic stroke, when they are having a high systolic pressure of more than 150, 160, then we should be aiming for a target blood pressure of less than 140. But certain recommendations and guidelines also talk about a systolic pressure head of maintaining between 110 to 140, going more conservative, going more restrictive, and that was also recommended. And now, what did the study say? There was the Interact 1 trial that was done basically, which compared the systolic blood pressure target of less than 140 versus less than 180 in patients who were having acute cerebral hemorrhage. And what they found was the hemodynamic progression was reduced by bringing the blood pressure systolic control from 180 to 140, but there was no difference seen in the mortality or stroke recurrence. So the impression that we can have from the study is that you might be able to maintain a better target of 140 or a 180, but going by any of these parameter control, basically the progression of the hematoma was reduced, but in fact did not have a change in the mortality or stroke recurrence. Then subsequently was the Stroke 2 trial. And here they found that a larger systolic BP reduction in the acute phase was associated with a lower risk of poor outcome, defined by death and disability. So we have to be very particular about these reductions. And obviously, once we have taken the reduction, then we should be able to control the death and the disability which is happening. So we have to have a good pressure control in patients who are having a acute hemorrhagic stroke. The Attack-2 trial, this was in 2016. This was the intensive blood pressure control in intracranial hemorrhage. And here again, it measured the control of blood pressure systolic of 110 to 139 millimeter of mercury versus the standard systolic blood pressure of 140 to 179 millimeter of mercury. But this study could not find any benefit and had to be terminated early for futility because there was no difference in outcome. So what was done earlier was again done, repeated in 2016, and they did not find any outcome by maintaining a pressure of less than 140 or a pressure of less than 180. The most recent was the Interact-3 trial. This was the intensive blood pressure reduction in acute cerebral hemorrhage trial that was done very recently and published in May 2023. And here they had not just taken the blood pressure control, that was one of the components, but they talked about the care bundle, about the immediate care that is to be given to the patients. Then we talked about the different quality tools which came into existence and what is the combination that we should be using, the different level of cares, the different components of care in the form of a bundle, which was important. And they did find that early intensive lowering of systolic blood pressure was associated with lower death and disability rate. So no doubt for patients with acute hemorrhagic stroke, what benefits are seen with an early intensive lowering of blood pressure cannot be negated, and we should be trying to bring down the blood pressure for these patients who are having an acute hemorrhagic stroke. Now the question is what level? So look at this chart which talks about the different guidelines. You had 2014 from the European Society, you had AHA in 2015, then you had the European Society again revising in 2018. So the clear recommendation is that for patients with acute hemorrhagic stroke, the systolic blood pressure should be maintained to less than 140. Whereas if you follow the European Society, the systolic blood pressure can be maintained between 110 to 140, obviously with the previous studies that were taken into reference. But we should be avoiding a systolic blood pressure reduction for more than 90 millimeter of mercury from the baseline. So don't try to bring it down from 220 to 130 or 120. Basically, we need to just taking it down gradually by 15-20% and to a target of less than 140. So the simple answer that we get for this question that we can follow is for the patients with acute hemorrhagic stroke, the target systolic blood pressure of 140 should be taken. Anything less than that is good. And we should also avoid the rapid fall or extreme reduction of blood pressure in these patients. Next, the subarachnoid hemorrhage. So we know that in subarachnoid hemorrhage, the high blood pressure is a risk factor for rebleed. Blood pressure of less than 180 millimeter of mercury systolic is to be targeted. And where in sectors or when patients where you have planned for an aneurysmal clipping or a coiling, there the blood pressure should be brought down to 160. And hypertension is recommended after securing the aneurysm for delayed cerebral ischemia, the DCI which happens after the aneurysm is secured. So in that time, you have to have an induced hypertension. So at this time, we have to ensure that the mean arterial pressure is more than 90 millimeter of mercury and that cerebral perfusion pressure is kept at more than 70 for high risk of vasospasm or delayed cerebral ischemia. So I think we need to be very clear about what parameters are to be maintained. We can't think arbitrarily, I fix my own levels, a mean arterial pressure of 65, 70. So I think if we have to go by evidence-based medicine, then we should be picking up the values which have been given in the guidelines, and we should be applying that because these are the results of different trials, and these are the recommendations which have come based on the consensus statement and a lot of evidence that is available. So again, there is a lot of difference in the different guidelines. You have the neuro societies, you have the European Society, you have the AHA and the ASA come into play. You can see the different years as how the guidelines have changed. But whatever, if you are securing an aneurysm before that, the systolic pressure should be less than 160. And the mean arterial pressure should be less than 110. And subsequently, once you have done the procedure for preventing delayed cerebral ischemia, induced hypertension is to be maintained where the mean arterial pressure is to be kept at more than 90. And some guidelines did not give any target also, but the others did tell us as to what pressure target should be maintaining. To have an answer to this question about what should be done in a patient of subarachnoid hemorrhage. So for these patients, target a blood pressure of less than 180 before aneurysmal clipping or coiling is to be done. And once it has been done, you can induce the hypertension after that by targeting a mean arterial pressure of more than 90 millimeters of mercury. I think that's how you can simplify. This is what is easy to practice, and we can go about in our day-to-day patient management. Now, finally, the traumatic brain injury, which is very common and which takes a lot of effort and a lot of management, because these patients come in good chunk, which have who are very serious, and they have a very bad prognosis too, and they have to be acted upon immediately. So we know that after the acute brain injury in a traumatic brain injury patient, the problem is the secondary brain injury, and we have a lot of reasons for that. But complications start at the very time of patients suffering acute brain injury. And these complications are because of BP alterations and hemodynamic instability. So the purpose of managing this patient is basically to prevent and minimize the BP fluctuation. Now we know both extremes of BP are intermittent. We have seen in the initial part, high blood pressure can cause more damage to the brain. The low pressures can indirectly affect the perfusion and can cause further damage to the brain. So I think that's very important. So to make it something which is achievable, for patients with TBI, you have to have a tight systolic blood pressure control between 100 to 110. Most of these evidences come from the Brain Trauma Foundation studies and guidelines. And this is the most recent one, which talks about what is to be done in a patient with Brain Trauma Foundation. So the targets are basically, you should be maintaining a cerebral perfusion pressure of 60 to 70, even though the level of evidence is 2, but still, yes, we should be. We should always be using early vasopressors, preferably noradrenaline, when these patients present with hypotension or shock. Restrictive fluid strategy should be avoided, and that's a weak recommendation. And also, we need to be taking into cue that the positive fluid balance should not happen. So that is detrimental, but these evidences that come for these are observational. But still, this is what evidence that we have is, whatever the level it could be. For patients with traumatic brain injury, crystalloids are recommended over colloids. And you have a lot of modalities available, the hemodynamic monitoring, the neuro critical care monitoring. But advanced hemodynamic monitoring should be used preferably when complications set in. Otherwise, blood pressure and fluid optimization are good enough to maintain the parameters in these set of patients, and that should be practiced at a larger scale. So what do the guidelines say? It basically says that for an age category of 50 to less than 70 years, the systolic pressure should be maintained at more than 100 millimeters of mercury. That's the target, hemodynamic target that one should be having. For patients between the age group of 15 to 49, here the systolic pressure, the younger group, the systolic blood pressure should be more than 110 millimeters of mercury. And once the people have crossed the 70 years, it's very nicely done. You have the different age brackets. So for the young, fairly young, and for the fairly old, you have to have a higher blood pressure, whereas that's a systolic blood pressure of more than 110. But for the age group of 50 to 70, there you have to maintain a systolic blood pressure of more than 100 systolic. So I think this is very simple. So to take it easy for our day-to-day practice, what should be done is that the target systolic pressure should be kept at more than 100. That is what the guidelines say. Keep it around 100 systolic for age category between 50 to 69 years. Whereas for age category of less than 50 and more than 70, please maintain a target systolic pressure of more than 110. If you're doing this, we are doing quite a lot of justice and good to the patient, and that is all evidence-based. So also to understand what's the prevailing practice, what people are doing across the world in terms of management of these hemodynamic targets. So this was published in 2022, and this was a research article which talked about a survey that was done by the European Society of Intensive Care Medicine as to what are the hemodynamic managements being done across the world. Now, the study quoted that advanced monitoring was used in only 28% of patients, and that too when these patients either had a cardiovascular complication in terms of a shock, a hypertension, or any LV dysfunction, or any other complication happening, or in patients who developed a deterioration in their neurological status. So it was not a first line. Yes, whenever modalities are available, we do apply the monitoring. But if not available, then it was actually done in those situations where these patients did show a deterioration in the condition. Most of the responders advocated a neutral fluid balance. That was 44 to 60% of these people. Nobody wanted a restrictive, nobody wanted a positive balance, but the tendency was to maintain a neutral fluid balance so that whatever is the intake, that is the output, and we don't add on or take off lot much of fluid. And as we all know, for acute brain injury, all studies have shown that normal saline is to be commonly used, and it should be applied for our day-to-day practice also. Hemodynamic management, as we talked about, the use of the different parameters, the use of the different targets like the blood pressure, the heart rate, the fluid therapy, the different monitoring devices to be used, there was a lot of variation seen, and that is expected. Hence the need for the guidelines to come in, more so the living guidelines, so that we can also take cue from the recent trials which are updated, and we don't have to wait for 3-4 years after having a guideline set. As you can see, the guidelines are of 2018-19, and there are a lot of research articles which do challenge the benefit of keeping those targets. So we have to have living guidelines or modifications done at an early time, but no doubt, if there is an ambiguity here, if you think so, the ambiguity is there all across the world, and there is a lot of variation seen. But our tendency and our learning and our good practice should be basically to know what do the guidelines say and how to apply in the form of a protocol or simple flow chart or a process flow in the unit that we work or in the hospital that we work. So to summarize, I think the strong, high-quality evidence for hemodynamic monitoring is still limited, despite considerable progress as we have seen, because the level of evidence is not very high. But at the same time, amongst the different hemodynamic parameters, what we find that the management of blood pressure remains the mainstay, and that is something which we need to be paying a lot of attention to, and we need to be guided by the available guidelines, despite the variation in practices and the recommendations which come about. So what we have seen about the different variations, but we have also seen as to what we can apply in a day-to-day practice, and that will be helpful for us for doing better to our patients. Thank you so much for the patient listening, and I think I have been able to put across the points and make it simple enough and simplify it so that all of us can apply it in a day-to-day practice. Thank you.
Excellent review.
Thank you.
A lot of concepts have been very clearly elucidated and described. Okay.
Thank you, Dr. Asif. You have kind of it's definitely indeed a challenge. I mean, many a time you have patients with neurological insults in your ICU. You're always confused. Especially if the patient comes in the night and some of the residents are there, and you have two patients on one hand, a patient with an acute ischemic stroke with high blood pressure, and then you have an ICU bleed patient or a traumatic injury. The hemodynamic targets could be a little contrasting, among these subset of patients. But what seems to be very, very clear from all the literature is one thing that we need to avoid hypotension. That seems to be, there could be some difference of opinion or variability with respect to what should be the higher target. But I think all the guidelines in all situations of brain injury clearly suggest that avoiding hypotension or having a blood pressure of less than 100 or 110 is universally bad. That definitely seems to be contributing to secondary brain injury. I also completely reiterate and agree with you on the fact that, as I have shown in the last slide, that the number of centers which are equipped with advanced neuromonitoring is very, very less. I think even in our country, a large number of centers probably do not have advanced neuromonitoring. Even we don't do the routine ICP monitoring, but we have other ways of looking at what's happening with the ICP, especially clinically, looking at the optic nerve sheath diameter, etc., etc. So in that situation, I think having this kind of clarity about what should be, so at least in the majority of the patients, we will not go wrong if we stick to whatever targets we have kind of highlighted. The third point is, I think again, all of us are kind of handicapped in not being able to assess the extent of blood-brain barrier in injury to the BBB that happens in different subset of patients with different pathological backgrounds. So that is something I'm not sure if we can kind of have some idea at the bedside about differentiating which patient has a more extensive damage to the blood-brain barrier as compared to which patient where the blood-brain barrier is intact. That is something that we need to probably look at. And lastly, I'm sure you would agree with me. We do come across certain patients with different kinds of brain injury where the autonomic dysfunction makes it extremely difficult to achieve the targets. You'll find that the blood pressure is very labile, and you give a small touch of noradrenaline, the blood pressure shoots up, and suddenly the blood pressure goes down. So I think these are some of the practical difficulties in certain subset of patients that you will see, which make these subset of patients one of the most challenging patients in our ICU.
Absolutely. Dr. Srinivas and Dr. Ghanshyam very rightly said. So we know what is happening and we know how it can be prevented. So there would be a lot of difficult situations still with us, but I think we need to make it very simple as to how we can apply it in a day-to-day practice. That's the whole purpose. And we might have very complex guidelines, but we need to make it very simple. I think one clear message should go not about presumption, but we have to have correct assumptions based on what is the evidence available to us. And we apply it. It's not that just we know it only for theoretical reasons. We also make it simple. We make it a part of our protocol and we apply it. And I think the compliance can go up and we can get better results. I think that's what is aimed for. We need to make it very simple and practical. And I think we should be improving this way. This is all about good clinical practices and that how it should result in betterment of the patient. Absolutely whatever you said, right?
No, your talk has given a very variety for a lot of, I'm sure, a lot of reasons, and all of us would benefit out there to have clear targets with respect to, because that's the blood pressure is one of the most often monitored parameter in our day-to-day lives, and most of us react to changes in blood pressures. So this presentation, I'm sure, is going to benefit a lot of them with respect to at least clarity about what should be the targets when dealing with different patients of brain injury, brain pathologies. Srinivas?
Yeah, I think that's it. I mean, blood pressure monitoring in an injured brain is actually a very interesting concept. And what we understand from the brain in terms of its autoregulation, its perfusion pressure, is now being understood that the same mechanisms work in different other parts of the body also. But the only thing is the brain being what it is, it's very sensitive to fluctuations in this hemodynamics, and we need to understand it. So a judicious use of clinical, biochemical, and sonographic modalities is probably good for us to understand the hemodynamic management of an injured brain. Thank you, Dr. Asif, for this. Next
Thank
week,
you.
Thank you, Dr. Asif.
Thank you, Dr. Srinivas. Thank you, Dr. Ghanshyam. Thanks to all.
Next week is the Telugu New Year Day. It's New Year Day for a lot of us in Telangana, Andhra, Karnataka, and Maharashtra. So we will take a break and we'll meet again on the 16th of April. We wish you all those who are celebrating the New Year a very happy New Year, and for all our friends celebrating the New Year, happy Eid. Enjoy your festival days, and then we'll meet again on the 16th of April. Have a good day. Bye-bye.
Good day. Festive greetings. Best wishes.
And I would also like to, I would also like to take this opportunity to invite you all to please register for the 9th edition of Hyderabad Intensive Care Symposium. It's happening between 10th to 12th May. It's one of the most extremely popular programs, which has been going on for the last 17 years. The name has changed over the last 9 years back. It used to be done as Critical Care Update. Since last 9 years, we are doing it under the name of Hyderabad Intensive Care Symposium. The full brochure and the agenda is available on the website, and we will again circulate the full program schedule. Some of the best topics, best speakers from across the country are there. So I request, please register for Hyderabad Intensive Care Symposium 9th edition. Thank you all.
Thank you.